Herkese iyi öğleden sonralar diliyorum.
Good afternoon. You've been very patient so far, and we've already exceeded our time. Therefore, I will try to conclude my presentation in a short period of time. I will focus on transcranial magnetic stimulation in TRD. My presentation will cover the following 4 topics. I will try to give you some general information about TMS. Then I will talk about TMS in TRD. I will try to give you some general information about the latest studies. Then I will try to explain how to use TMS in our clinical practice and the things that we have to attach an importance to, and future directions for this therapy and its alternatives. Earlier speakers also made a reference to the treatment of TRD, and they all said that this would be a marathon and not a sprint. Of course, we need different options, different alternatives for the treatment of such a marathon. ECT, of course, is one of the primary and the most effective treatment options for patients with severe TRD. Well, that should be the topic of another discussion, but we all know that DBS can be very effective. DBS techniques might be very effective, and we arrive at this conclusion because ECT, of course, is beneficial. Neurostimulation techniques can be studied under 3 different headings. One of these options is deep brain stimulation. It is used very frequently, especially in Parkinson's, for example. Magnetic seizure therapy is another investigational therapy, actually. This is similar to ECT, but a magnetic form of ECT. Other than ECT, there is one more technique that is approved by the FDA. Actually, there are 2 techniques. One of them is vagal nerve stimulation. It is done by a device that is placed on top of the chest wall. It has been used for epileptic therapy for a very long time. That is why we have enough data about its safety, and it can also be used as a method in TRD. But today I will focus on the second method that has been approved, which is TMS. TMS was first developed by Barker in 1985 and was clinically used by the same researcher in the UK. An electromagnetic device that non-invasively delivers a rapidly pulsed magnetic field to the cerebral cortex in order to activate neurons with a limited volume without inducing a seizure. This can be the general definition of transcranial magnetic stimulation. There's no tissue damage, theoretically there's no pain for the patient, and there's no electrical resistance. There are different coils that are being used. Usually we use this coil, which is shaped as an 8, but there are others that have the shape of H, and these are usually used for deep stimulation. TMS devices might have many different subtypes. If they work with a frequency over 1 Hz, then they're considered to be high-frequency TMS devices. They activate cortical firing and increase blood flow. There are also low-frequency TMS devices, and these inhibit cortical firing. Single pulse, paired pulse, and repetitive are some other subtypes. If there is one stimulation at a time, then it's called a single pulse. Monophasic systems, that is, single pulse systems, are much more common in neurological research. They're also used in cortical mapping and brain research. They can be used for the functional assessment of CNS pathways. and they're mostly diagnostic tools. Biphasic systems are therapeutic systems. They're either used for the investigation of cognitive systems or in psychiatry, especially indicated for the treatment of TRD. They can also be used in the fields of neurophysiology or rehabilitation. These are repetitive TMS systems. Role of TMS in TRD. FDA approved this technique in the United States in 2008. This was covered before in earlier sessions. There is a very common definition of TRD. These should be patients that do not respond at least to one antidepressant. And these can be used, of course, on patients that are not on antidepressants right now. There are many studies in the literature on TRD and TMS in TRD, but I will try to give you a couple of examples from some recent publications. All of these studies were published in 2013. There's one series with 307 patients. Depression scores in these patients were found to improve significantly. Another study from Cousin and Doherty. This was published twice actually. In 2012, when they first published it, they said this was effective in mild depression cases, but they were criticized severely, therefore they had to publish a correction. And in the correction, which they published in 2013, this time they claim that they have strong evidence in the favor of TRD. This is a publication from Turkey which was carried out on 65 patients, and during the course of 6 weeks, TMS was found to be effective on TRD. This is a study from our own clinic. It hasn't been published yet, but depression scores seem to have improved in these patients as well. In the reactive depression subgroup, there seems to be a positive impact on the anxiety scores as well in our study. So many studies find TMS to be effective against TRD. However, all these studies were conducted on small patient populations. And due to the features of the device and the practice itself, it is very difficult to reach one common standard, and it is very difficult to compare these different studies. Maintenance studies show that TMS reduces relapse. And what if we compared this efficacy with ECT, the efficacy of TMS with ECT? Several reviews have been published on this issue. And one of these reviews compared 9 high-quality study designs. 2 of these studies said that TMS is not more effective than ECT. One study says TMS is less effective than ECT. Another one says there seems to be no significant difference, and in all the other studies, TMS was found to be less effective than ECT. So, all in all of these studies, TMS seems to be less efficacious than ECT. How about the advantages of TMS? TMS, first of all, is a new option, and it's a different option. And in patients that do not respond to other forms of therapy, it's a new weapon in our toolbox. It is safe, it is effective, it is well tolerated, there is a very low seizure risk. It's non-invasive, which is excellent, of course, because deep brain stimulation requires surgery and anesthesia at the same time. So it's good that this one is non-invasive. This is an outpatient procedure, and it's a simple procedure. It helps us avoid polypharmacy, because, as Cemil said, we sometimes have to try different drugs and different combinations of drugs, which of course have certain side effects. And refractory cases develop some additional comorbidities as they get older, or women, of course, might get pregnant, which might keep us from choosing the pharmacological options. Therefore, this is a good option for us to have. And of course, independent from personality traits, TMS can be used. But of course, we have to keep in mind that TMS might be more effective on extroverted patients. There is some evidence in this direction. How to use TMS? I will not go into technical issues. I will just try to give you a brief overview. This is not an invasive process, as I said before, but it's still a magnetic field. Therefore, we have to receive the informed consent of the patient. We have to set a motor threshold, a standard threshold for the stimulation of a certain muscle. We usually prefer higher frequencies and left dorsolateral prefrontal cortex, but right DLFC, low frequency, is another option. We of course have to know the configuration and the attributes of the applicator that we're using. The diameter is important, as well as the coil. And output stimulation parameters are also parameters that we have to have an idea about. These have to be calibrated and standardized. Standardization, of course, is not that simple. Well, there are many devices that might have an impact on the magnetic field, such as mobile phones or TVs. Cardiac pacemakers on the body might also have an impact on the magnetic field. Therefore, we should have a well-isolated room. And now we're in the phase of actually constructing such a room in our own clinic. We have already built the room where there is no external magnetic impact, but it hasn't been made functional yet. It's not in use yet. Contraindications. We have to be very careful with metallic objects, especially in or near the head. For example, if the patient has anything in his teeth or any hairpins, these should all be removed because they're contraindicated. We have to also warn the patients, and some of this information should be approved by the patient in written form. Depression might worsen. There's of course risk of ineffective therapy, and there's a very slight risk of seizures. Therefore, we should be prepared to take action against a seizure in case we run into one. We don't have clear data about long-term effects of this therapy, so we have to be very cautious in our explanation of the process to the patient. All the users have to be well trained, and of course we have to be careful about the technical issues about the magnetic system. There are of course certain side effects. Pain is one of them. Headache and facial pain seem to be the problem in some patients. Patient choice is also very important. Patient selection is important. It might cause irritation on the skin of the head. There is some data about hearing loss, and we have to be careful about the problems that might stem from the electrical system. How about the future direction? Well, technical parameters have to be set very clearly. Further research is definitely needed because we lack standardization in this regard. It also matters where we apply the TMS. There's of course the 5 centimeter rule, but we can still use a navigation device to point the therapy to the right site. Well, MRI, SPEC, or PET can be used, of course, to verify your results, but then it would be too costly. Brain tissue properties can have significant effects on the neurostimulatory fields, and resistance might differ from patient to patient, and there might be personal differences in flow. Many studies use biological markers to check the efficacy of TMS. Mostly imaging methods were used. But there are some studies that show that BDNF is a good predictor. It's usually used together with EMG, but EEG can also be useful and can give us additional information about the results. It can be used as a measurement, or the measurement can be done with all three methods: EMG, EEG, and TMS together. So this can be a novel and efficacious treatment method for TRD, but schizophrenia is another option. Catatonia, OCD, addiction, and rheumatological diseases. There are some ongoing studies about these diseases and the impact of TMS on the treatment of these diseases. Our new study design should focus on the indication of use, inclusion and exclusion criteria, treatment parameters, and the type of the design as well. It has to be prospective and randomized as well. Device effectiveness is important, as well as safety. User training is also important and should be further studied. Thank you for your